Great. Thanks very much, John. Take it away.
Right. As you say, Jeremy, it's an important public health problem worldwide, one of the neglected tropical diseases. And again, not one that we see a lot of. So I thought I would just start with a couple of cases that we actually have dealt with. And then go on to some of the more, some of the more general stuff. So I apologize in advance to the DTM&H students, and both present and past and future, maybe. Some of this will be somewhat familiar, but I hope there are enough other people to, to dilute out that. So this is a lady who came to see us several years ago now with a complaint of a non-healing ulcer on her upper arm. And that's a close-up of that ulcer. And as you can see, it has got that sort of chronic fibrotic edge to it. Not particularly painful. And this is the history. And really, this is a telephonic diagnosis. Once we hear about the person's travel, she'd been on holiday in South America, in Peru and Brazil, and had traveled around for quite a long time. And the ulcer started a few weeks after her return. And I guess the point here is that she had consulted several doctors, had been treated with various things, including an excision biopsy, because they were worried that there was a malignant basis to this lesion. And it had been biopsied, and the histopathological report was of no pathogen seen. So this is one of her own holiday snaps. That's the patient at the Iguazu Falls, I think, in whichever side she was on. And this is the list of treatments and assessments she had had. So at this point, she was a bit fed up with the medical profession. And you can see there are repeated topical treatment, some systemic treatment, and eventually she landed up with Lucille, and Lucille and I saw her. Well, in fact, we had made the diagnosis before we saw her, because as I said, this is really a telephonic diagnosis. So I asked to see the sections, and they were sent from the private lab, and this is what I saw. So this is the H&E stained skin biopsy, and it's very clear that there are numerous intracellular and extracellular small particles. And I think there's a higher power view. It may not be that clear in this picture, but in some of them, it was clear that these had the typical morphology of Leishmania parasites, and I'll talk about that a bit later. So, if you don't get a clear view of the organisms themselves, there is something of a differential here. I mean, a yeast infection of some sort. It looks similar, but as I say, we could see the typical morphology, and the history and the clinical course really suggested or clinched the diagnosis. So she was, after some delay, the routine treatment, which is a pentavalent antimonial, was obtained, and eventually, once she'd completed the course, a good clinical outcome, as you can see there. So the next case was one that we looked at in combination with the pediatric hematologist at Charlotte and Kirky. This was a child presenting with fever, pancytopenia, and splenomegaly, a 9-year-old of Greek descent, born in South Africa, and she was originally seen because of a complaint of fever for about a month. There was really no significant previous medical history, no drug history, no recent travel, and no family history of note. So at that stage, the clinical exam was essentially normal. The only real clinical finding was that of lethargy. So these are some of the lab results at the time, and the abnormal ones highlighted. So there was something of a pancytopenia, marginal increase in liver enzymes. I'm not quite sure what you expect the hemoglobin electrophoresis to show, or the HPLC, but anyway, that was the result there. So she was admitted. So all this happened in private practice. She was admitted, given antibiotics, and discharged. Then she was seen again a few months later with fevers again, complaining of tiredness, weight loss, and easy bruising. So some progression of the clinical picture. At this point, she was somewhat underweight, ill-looking, with a low-grade fever, lethargic, pale. She had some scattered bruising, no obvious petechiae, no skin rashes or lesions, some shotty inguinal lymph nodes. Not jaundiced, chest was clear, etc. The abdomen showed there was a large splenomegaly, firm, and on the central nervous system side, again, nothing focal, no meningism, but just this picture of lethargy. So, in summary, we've got this young girl with a history of fevers, tiredness, and ill-looking, pale, with bruises, and the splenomegaly. So this is how the hematologists approached the approached this. This was their sort of working differential of splenomegaly, starting with malignancy of various sorts, hemoglobinopathies, moving on to infectious causes and listing malaria, leishmaniasis, and schistosomiasis, all of which is quite appropriate. Portal hypertension, and then storage disorders. So, as you can imagine, the next step, active step, was a bone marrow examination. But this is the later full blood count, and as you can see, the pancytopenia is somewhat more profound, and the activity markers showed some activity, inflammatory activity, but the enzymes had gone down, interestingly, the liver enzymes. So the bone marrow showed a hypocellular picture, but there was hemopoiesis along all the cell lines. No dysplasia, no overt infiltrate, no blasts, but prominent macrophage activity and numerous intracellular organisms in the macrophages. And they queried seeing a paranuclear dot. And we had a look at the smears with them. And again, you can see these intracellular organisms. And I think if you look carefully, for example, here at this one, you can see the nucleus and a dot next to it. Same over there. So this actually shows the advantage of a smear over an H&E section, because you do get a clearer picture of the organism when it's tends to flatten out and show more detail. So the differential at this point was a disseminated parasitic infection and or a disseminated fungal infection, although the organisms don't really look like fungi or yeast. And so we looked at the slides with them and noted the Leishmaniasis, Leishmania parasite, but interestingly, there seemed to be another organism which was possibly intracellular yeast, and we wondered whether it could be histoplasma. But these were much more scanty than the Leishmanias. So these were some other investigations from that time. That was the beta-D-glucan level. The urine histoplasma antigen assay did give a low positive result, with the proviso that this was still under investigation or under evaluation, and too much store shouldn't be put on it. But it did seem to correlate to some extent with what with the microscopy. Cultures were negative. There was some query about the HIV, but they decided this was it was actually negative. There was a problem with cross-reactivity, because the HIV PCR was negative. So this looks like visceral leishmaniasis. And of course, the question is, it's not endemic in South Africa. And so where did she get it? Where did she acquire it? So again, it's the travel which gives you the answer. 18 months previously, she'd been on an overseas trip, and the main destination was Greece, her ancestral home in a sense, and she had spent quite a lot of time there in various places, in Athens and some of the islands, and then elsewhere on the mainland. And that's, I guess, Greece in a nutshell. But these are the red circles show the sites that she visited. Along with her family, who were all completely well, incidentally. So she was started on amphotericin B, and she got it, well, there's a regimen. And on this regimen, she improved clinically. The fatigue resolved and she gained weight. Splenomegaly resolved, and the bone marrow recovered. So at the later assessment, it was essentially approaching normal, and she had made a good clinical and hematological recovery. So this report was actually prepared by Rose van Wintel, who's one of the pediatric hematologists, or was at that stage. Okay, so looking at the biology of leishmaniasis, all forms, so we've mentioned cases of cutaneous leishmaniasis, visceral leishmaniasis, and there's another form, which we'll come on to shortly. They're all transmitted by sandflies, which are small biting flies. And there's a greatly magnified image of one. But these are really, really small flies, a couple of millimeters in size. But from an entomological point of view, they're identifiable by these wings held in a V shape over the body and the very hairy fringes to the wings and the body. Right, so transmission occurs when the infected female sandfly bites its host, which is not, there's a variety of hosts, suitable hosts amongst the mammals. Now, during this feeding, she transmits the infective stage of the parasite, which at this point is called a promastigote. So these are elongated forms with an anterior flagellum, a nucleus, and this paranuclear dot or kinetoplast, which marks the origin of the flagellum. Once these promastigotes are inside the mammalian host, at the higher body temperature of a mammal, once they're ingested by the macrophages and other phagocytes, they transform into amastigotes, and they lose their external flagellum, become rounded up, and parasitize the parasitophorus vacuole, which is of course designed to kill organisms. But these parasites have evolved to survive the somewhat toxic conditions inside the vacuole, and multiply and spread from there through the phagocytic cell system, either spread locally, or can be transferred to the other organs of the reticular endothelial system, and elsewhere, in some cases, elsewhere in the body. Now, in the skin, these infected cells, phagocytes, are picked up during feeding by the sandfly. The amastigotes are released in the midgut of the sandfly and transform at the lower environmental temperature that the flies are at into the promastigotes. And they multiply by a form of binary fission and migrate to the pharyngeal valve and activate the the various genes which allow them to parasitize the next host, at which point they're called metacyclic promastigotes. In other words, metacyclic means at the change in the cycle, basically swapping from one host to another. That's all that metacyclic means. The procyclic ones are the ones actively multiplying ones in the sandfly, and are not immediately infective until they become metacyclic promastigotes. And that, for all forms of Leishmaniasis, is the transmission cycle of the parasite. So these are promastigotes, which are quite not difficult to culture in the right medium. And so you can see the anterior flagellum. It's a rather poor photo, I'm afraid, so you can't see the detail inside the parasite, but basically the kinetoplast is anterior to the nucleus, which distinguishes them from, morphologically anyway, from trypanosomes, where the flagellum emerges from the kinetoplast or near the kinetoplast, posterior to the nucleus. And of course, another difference is these don't have any sort of undulating membrane. And anyway, the insect host is completely different. So there's really no confusion if you know what you're looking at and where it comes from. So these are amastigotes, and as we're pointing out here, the typical features are these spherical particles with a nucleus and this kinetoplast, which also contains DNA, so it has the same staining characteristics as the nucleus. And they start off inside the phagocytic vacuole of the macrophage, but you also, and then they burst out. So you find them both intracellularly, cellularly, and extracellularly in whatever tissue they're infecting. So ultrastructurally, at this point, the amastigote, it doesn't have an external flagellum, but it has an embryonic one concealed inside the cell itself. And here you can see it nicely in this flagellar pocket, and with its origin near the kinetoplast, which is this part of the mitochondrion which contains a very tightly coiled DNA circles, which has genes that are required for the metabolic processes in the mitochondrion. And then there's the nucleus. So these are the structures that you can see quite clearly on a stained preparation, the nucleus and the kinetoplast. You don't see the flagellum because it's too rudimentary at that point to show on on an ordinary light microscopic preparation. Well, that's the same thing again, just to reiterate that once you see that combination of nucleus and paranuclear dot, you really know you're looking at a Leishmania and not something else. And same thing again there. And this is the same. This is the first patient, the cutaneous leishmaniasis case. I've already shown you this. Just pointing out what we could discern on the original section. So Leishmanias are complicated in that there are a number of species and a number of genera and subgenera. And the disease associations are somewhat typical, but there are some variations, and sometimes some unusual association. So cutaneous and mucocutaneous leishmaniasis in the old world, which is Africa and Asia, are caused by Leishmania tropica, Leishmania major, and Leishmania ethiopica. I'll come back to the asterisks just now. In the New World, so that's Central and South America, cutaneous and mucocutaneous leishmaniasis is caused by these species, Mexicana, Amazonensis. There are several other species, and Braziliensis. And only certain species belonging to a subgenus are responsible for mucocutaneous leishmaniasis, but it's really a New World disease. Then, as far as visceral leishmaniasis is concerned, we have around the Mediterranean and in parts of Asia and the Far East, Leishmania infantum, which is the same as Leishmania chagassi. And chagassi is the name given to it in South America, but it's the same species. In India and East Africa, we have Leishmania donovani, and I've mentioned Leishmania infantum, stroke chagassi in South America. Now, if we look at some of the variations of leishmaniasis, we have this condition called diffuse cutaneous leishmaniasis, which is caused by certain species, Leishmania ethiopica, which would otherwise cause cutaneous leishmaniasis, the ulcerative form, and Leishmania amazonensis. Sometimes these present as diffuse cutaneous leishmaniasis. Then in India and East Africa, Leishmania donovani, we've got this condition called post-caloazar-dermal leishmaniasis, which occurs after treatment, where you get parasites colonizing or parasitizing the skin and not being, even if the patient's recovered from the reticular endothelial system or the systemic infection. So caloazar, just to explain that, it's the disease given in India to the disease, and it translates as black fever because of the clinical presentation of the patient, which includes some pigmentation changes sometimes. Geographically, this is the global extent of leishmaniasis, and both of all forms. I'll show you the distinction between the geographic distribution of the other ones, but just point out that what is now Namibia had a focus of infection discovered fairly recently in the 80s, I think, or 70s, but very few human cases. And it doesn't seem to have recurred. This gives the gradation by intensity of infection or transmission. So the highest transmission areas of visceral leishmaniasis, as reported at this point, are East Africa, India, that would be Bangladesh, Iraq, I suppose, and Brazil, with much lower transmission rates in some Mediterranean countries, both south and the north part of the Mediterranean, Middle East, Central, other countries in South America, and then the Far East. I know these maps are rather old, but they do give you a bit more detail as to which parts of these countries are involved as opposed to the whole area. So in India, it's really the eastern side of India, and particularly Bengal and Bangladesh up there, where visceral leishmaniasis was a problem. Again, it's not the whole of China, but that area of China over there. Green is cutaneous leishmaniasis. So again, you can see it's doesn't really involve the whole of any country, any of these diseases. There's a patchy distribution related to the suitable conditions for the animal hosts and the vectors. This is Africa, Mediterranean, again visceral in red, cutaneous in the sort of brownish color, and then areas where you get birth. So just looking at the WHO map, I think the distribution around the Mediterranean is somewhat reduced since the time this map was produced. You know, on the whole, it remains similar. In South America, again, it's a patchy distribution. It's not whole countries, except maybe over here, Panama. Looks like quite a large section of Panama, at least, but otherwise patchy and rather restricted distribution or occurrence of visceral leishmaniasis, more of cutaneous. So this shows the variable presentation of cutaneous leishmaniasis. Now, this picture at the top left is actually one of the Southwest African, or what was then Southwest African, Namibian cases of leishmaniasis. And this was shown to be transmitted by sandflies, which normally feed on hyraxes in a particular ecological setting where hyraxes live on sort of stony koppies, and the humans that got infected were ones whose farms or whose farmhouses were close to that sort of habitat. And it seemed to be very focal. It was a different species related to Leishmania ethiopica, I think. But the molecular genetics and the phylogenetics, I think at that stage, you know, today's sophisticated methods weren't available, and it was never adequately investigated. So it might be a different species or subspecies, but that remains unclear. But as I said, the number of cases were never large, and it seems to have disappeared as a clinical problem. These in the top row here, these were both patients who had traveled in South or Central America and presented back here with cutaneous leishmaniasis. We've also seen some similar patients or similar appearances of skin lesions in patients from who traveled to Egypt and Israel, where the disease is also endemic. These are published pictures of the various presentations of cutaneous leishmaniasis, and so you can see it is somewhat variable. This is a more diffuse cutaneous appearance, and it can be cosmetically disfiguring, although the natural course is self-healing. If it's in a cosmetically sensitive area, for example, on the face, one wants to treat and not just leave it to heal by itself, because some scarring is possible. So visceral leishmaniasis, basically the same route of acquisition, with the sandfly bite inoculating organisms, but then they spread via the phagocytic system to infect mainly the organs of the reticular endothelial system, and therefore the prime presentation physically is hepatosplenomegaly. The best place, safest place to look for the organisms is in the bone marrow, and it's predominantly a disease of children in these endemic areas. And untreated, it has a high mortality, access to treatment in some of these countries is difficult. Certainly access to what is now regarded as optimal treatment is a problem. Now, with mucocutaneous leishmaniasis, this is caused by Leishmania species belonging to the subgenus Viania. So it's only a subset of the Leishmanias one can acquire in South America. And it starts off as a cutaneous presentation, which heals naturally, spontaneously, as I mentioned, and then at a variable period, the parasite metastasizes and sets up a local mucocutaneous infection, which can be very disfiguring. You get erosion of the mucocutaneous tissue, particularly of the upper respiratory tract, the nose and pharynx and so on. And it's the reason why all cutaneous lesions acquired in South America should be treated in case they are caused by the subspecies or the species of the subgenus responsible for mucocutaneous leishmaniasis. Now, I've never come across a real case turning up in this country. I think Danasha probably has seen cases in at the Gorgas course, or anyone else who's done the Gorgas course will have seen these cases. I don't know. Danasha can comment if she is here. What about treatment options? So the classical treatment for leishmaniasis is the pentavalent antimony compounds, and they're different formulations, but they basically contain the same active ingredient, which is antimony compounds. Then amphotericin B, particularly for visceral leishmaniasis and mucocutaneous. The drug of choice for visceral leishmaniasis nowadays is something called miltefosine. But this is not readily available in many places. There's a very limited supply. It's only made by one company, and it's very expensive. And therefore, special provision has been made by the WHO to acquire supplies of this for countries that really can't otherwise afford to get it through things like the MSF. Then, as far as other drugs, older ones are paromomycin, which was used to treat visceral leishmaniasis, and topically for cutaneous. Pentamidine, again, this is now regarded as obsolete, I think. The azoles like ketoconazole and itraconazole may have some utility for cutaneous, but probably not good activity or sufficient activity for visceral leishmaniasis. The cutaneous forms healing can be speeded up by local heat or local cryotherapy, and various combinations of drugs have been used, which we haven't got time to go into here, but this is, if you're interested in treatment of visceral leishmaniasis, this is that's a reference. Just quickly, in terms of the importance of zoonotic disease, these are all parasites of various animals, as I mentioned, particularly rodents in the Old World cutaneous leishmaniasis, the great gerbil being the really important one. And these rodents get bitten in places where the sandflies have access to relatively hairless skin, like the ears and the nose. And that you can see clinical evidence in the rodents of ulceration and so on. Not a good photo, I must say. The visceral leishmaniasis animal reservoir in many places is the dog or dog family, and dogs get ill. They become emaciated. Their nails grow, so they get what's called onychogryphosis. As not only domestic dogs, but members of the dog family that may be wild, like jackals and so on. In Central and South America, a whole range of forest animals are reservoir hosts. Rodents of various sorts, opossums, sloths. So there's a vast animal reservoir of the parasites. As I mentioned, for visceral leishmaniasis, the safest specimen to obtain is bone marrow, as opposed to splenic puncture or liver biopsy, although that is done. In some places, splenic puncture in particular was done routinely. An old test was called the formal gel test, where because patients have such a high level of gamma globulin in the plasma, a drop of formalin would cause it to gellify, solidify. But again, that was that's obsolete now. It's a historical reason. Various serological tests are available in various places. None in this country, because there's no demand for them, of course. The method of sampling cutaneous lesions, formal biopsy and sectioning is good, but in areas where that's not readily available, obtaining tissue from the edge of the lesion by various means, aspiration, and what's being demonstrated here is a root canal probe with little barbs on it, which is good for, it's not very traumatic, but these little barbs catch enough tissue to make it a useful way of sampling the edge of these lesions. And it's the edge where the parasites are at highest concentration. And then animal studies are, I think, used to be done. I think nowadays it's probably not used as a routine diagnostic procedure anywhere. And one can culture these organisms. Again, this would be done in areas where, this is a clinical problem. The labs are equipped to do that. Just to mention that at NICD, we do have a PCR for Leishmania, a pan-species one, which is not accredited, but it is. We have, I guess, verified it with material that we've got. And I think I've left some time for questions. Danasha, I don't know if you want to comment on your experience in Peru.
Thanks, John. Danasha, you can unmute yourself if you'd like. Otherwise, while we get it, I managed to, with Rob Davidson's permission, see his video of splenic aspirates. So it stuck with me, as I'm sure it has for most people who've seen it forever. So I'm just going to play it 30 seconds, if everyone's okay with that, because it's quite fun to see what people think of questions. Hopefully you can see the video at this point, and then let me play.
Oops.
It is.
Well,
it's quite jarring when you see it.
yeah, rather them than me.
Yes. Apparently, I mean, as with most things, I think in medicine, you know, where they see a lot of it, like in Ethiopia, there, or Sudan, I can't remember where that was from, but you know, they're very good at it, very low complication, but certainly not something I would try without many years of experience. Dinesh is just saying in the chat she's having mic issues, but she's seen mucocutaneous leishmaniasis, but not visceral.
Yeah.
We had a case a couple of years at Helen Joseph, which again was an Ethiopian gentleman who traveled in, and yes, some fantastic pictures from your lab coming through the investigates. So very, very there you go. Michelle, you've been nominated by Dinasha about whether you had a suspected case recently. In the meantime, oh, sorry, yeah, go ahead, Michelle.
Yeah, so we had a gentleman who traveled from Ethiopia not so long ago, presenting with a massive splenomegaly. Managed to get a splenic aspirate done, obviously under ultrasound guidance with the radiologists doing it, and me standing in the corner very afraid the whole time. And he actually landed up being a Plasmodium vivax. Prof Frean knows the case as well. So yeah, it's quite a thing to witness, I must say.
Oh wow, that's good to have the diagnosis. And hopefully his sleep is okay. Always dangerous. But no, as you said, it may be necessary. I mean, it is the most sensitive spot, if I'm not mistaken, John. It's just that it's clearly not as accessible as, and not as safe, rather, as a bone marrow if you can do it. But obviously some of them may be bone marrow negative and spleen aspirate positive.
Yes, I guess so, yeah.
And then I had a question about the cutaneous leishmaniasis, the spread. So presumably the sandfly could bite, you know, for onward transmission, the sandfly could bite those lesions and you know, and get some of the mastigates that way. I don't know. And then, as far as I understand, though, it can actually bite or pick up some of the infectious forms from other non-infected skin or even blood. I don't know if that's your understanding too, John.
Yes. I think the parasites spread quite widely, even in the skin, even if they don't cause ulceration everywhere, and therefore the parasites can be available that way. But I suspect that most sandflies will have got infected from feeding on the animal hosts, because that's probably their preferred source of blood anyway. And humans really are sort of incidentally involved. The only place where humans are regarded as the reservoir as well is in West Bengal, in the classic Kala Azar country. There it seems that the parasite or the disease can persist even in the absence of a recognized animal host.
Yeah.
Or animal reservoir, rather.
Yeah. No, it's a fascinating thing. And also, it's so interesting that there's so many different manifestations, presumably different species. And well, in many cases, we know it's different species. But like you said, for example, the Namibian cases, maybe different subspecies at least. Because it would make sense. I mean, you know, it does seem to be geographic isolation between them, at least as far as we're aware. So it would make sense. It would be a different, at least subspecies potentially, although it will have to wait. I mean, you're saying there's only a few. I didn't realize there were any cases in Namibia, but you're saying it's mostly animal cases, but occasional cutaneous leishmaniasis, which is.
It's really a historical story right now, because there were, a handful of human cases, and then it's, either people moved away or something changed and the disease really disappeared. And they were never very, it was never very widespread, or it was never widely known, I think. It remains more of a sort of, epidemiological phenomenon rather than a clinical problem, and really a biological, biological mystery as to what the parasite actually, what its affinities are, which species it is. And it would be probably quite easy to sort out nowadays with whole genome sequencing and so on, but that simply wasn't, available in the 1970s and early 80s.
And John, the question with visceral leishmaniasis, or even cutaneous, if you're aware, but the sort of the interplay with HIV. I mean, HIV seems to make everything worse in general, but I think that is definitively true of visceral leishmaniasis, isn't it?
Yes, it is. There is an association with HIV. It's quite a strong one in some places. It's one of the opportunistic infections that one has to be aware of. I think it's particularly a lot of cases have come out of southern France and Spain associated with HIV, from what I remember.
Yeah, holidaying in the Mediterranean, probably. Like your other patient. And then one other question that someone sent through is about controlling this disease. So, I mean, there are measures for sandfly control itself, and then obviously particular reservoir, animal control potentially, depending on the species. I don't know if I mean, are these programs successful? I mean, are we moving towards eradicating this disease, or do you think, I mean, well, not eradicating, but at least limiting, I guess, with animal reservoirs probably won't eradicate it, but are we moving towards a place where the numbers are much fewer?
Certainly, quite a lot of effort in the past went into controlling the disease, or at least limiting access of human populations. Citing settlements away from suitable areas. I think the Central Asian Soviet republics, many of them had put a lot of effort into rodent control, in the sense of disrupting the ecology, so it was unsuitable for rodents, plowing up their burrows and so on, so they would go elsewhere. But with as with many zoonotic conditions, diseases, it's really never going to be possible to eliminate it, or certainly not eradicate it. They're just it's just not feasible. To be honest, I haven't really kept up with the public health aspects of what's being done to at least control it. But I think as one of the neglected tropical diseases, I think the answer is probably not enough is being done, and more needs to go into it. But I think the focus in that sense in that context is more around getting access to effective drugs like miltefosine, and making sure that at least treatment, diagnosis and treatment is optimized, rather than trying to tackle the biological pathways that lead to the disease.
It's a great point. And then just the final question, which kind of leads on from that, is, I mean, in the unlikely event that someone does have a case here, I mean, we do see some cases from time to time. What's the best way to get hold of treatment? Because there's amphotericin clearly, which everyone has for the visceral form. and for any of the other agents that may be required, I mean, should they contact through the NICD, or what do you think the way forward is if you do have cases?
Yes, they're welcome to contact us. We can put them in touch with the with the WHO office that has a program that makes these drugs more readily available. In the case of miltefosine, it was required for a local case, not of Leishmaniasis, but another disease where it's the drug of choice, and it was obtained via MSF, actually. MSF seems to be the sort of conduit for some of these neglected, these drugs for neglected tropical diseases.
Yeah, thank you.
So the bottom line is we can put people in touch with the relevant people at WHO, and they really do make an effort to assist.
Oh, great, thank you. Dinesh just put some interesting stuff in the chat about WHO can supply miltefosine. They're supplied for the visceral leishmaniasis, but unfortunately not acanthamovitis. I remember this was maybe about 8 years ago, and we had the case at Helen Joseph, and at that stage they weren't supplying miltefosine, but we tried our luck with them to see if we could get liposomal amphotericin B instead of normal amphotericin B, and they said to us, seeing as we're an upper middle income country and we had amphotericin already, we should just use that, the deoxycholate form. We did try, but no, they are, I know, very, very helpful for a lot of these drugs which aren't available in the country already. And yeah, yes, they do make a huge effort, as you say.
For the first patients that I presented, the one with cutaneous leishmaniasis, I think it was megalamine was obtained via WHO, actually. Yeah, because obviously it's not, there's no local supply.
Yeah. No, great. Thank you very much, John. That is fantastic as always. John is a real pro, so it's wonderful to have you give us this lecture, John. We're hugely appreciative. A really, really awesome lecture. Thank you.